Welcome everyone to this second journal club of the year, the EANO Youngster Journal Club. I'm gonna do a quick recap about what the Youngster Journal Club is. It's a 1 hour webinar discussing cutting edge research in an interdisciplinary way. And we have at the end lively discussion, and also I hope that this creates networking opportunities. Behind this journal club, there is a team that's organized uh, these webinars. So, and we have Dasha and Philipp presenting today. So happy to have them helping to organize this. Also, we accept youngster presenters. If you want to join us and collaborate, also proposing any new manuscript, we are happy to receive it and consider them. Also, a little bit promotion about the next EANO. For the EANO Youngster session, we're going to have a mentoring session, our ProCon, the panel discussion, and for sure the Youngster networking event that is so popular. So check out before the tickets are sold out, and also check out the whole program. Also, before to start, just a reminder that all the journal clubs are uploading the EANO YouTube channel. And when we start the discussion, please don't use the chat, use the question and answer box to drop off your questions so we can read it and discuss and discuss them. So today we are going to discuss a microbubble enhanced transcranial focus ultrasound with temozolomide for patients with high-grade glioma, a multi-center open-label phase 1-2 trial paper. And the presenter are going to be Dasha Fedorushkova, MD, PhD candidate in neuro-oncology at the Netherlands Cancer Institute, Amsterdam, the Netherlands. Philipp, a neurosurgeon for University Hospital of Erlangen, Friedrich-Alexander-University Erlangen-Nürnberg, and Germany. And as a senior discussant today, we have one of the author of the paper, Meng, assistant professor, University of Toronto, Canada, Antonios Pouliopoulos, and senior lecturer in therapeutic ultrasound at King's College London, United Kingdom. As a junior discussant, we have Akke Bakker, a technical physician at Princess Máxima Center for Pediatric Oncology at UMC Utrecht, the Netherlands, and Nico Teske, neurosurgery resident at University Hospital of Erlangen, Friedrich-Alexander-University Erlangen-Nürnberg, Erlangen, also in Germany. So Dasha, the screen is yours, and please don't hesitate to send your question to the question and answer the Dropbox. Go ahead.
Thank you so much, Antonio. I will share my screen.
Yeah.
And I think you'll be able to see it right now. Am I correct? Wonderful. So, good afternoon, everyone. My name is Dasha Fedorushkova. I'm an MD PhD candidate from the Netherlands Cancer Institute. And today I will be taking you through some key concepts to better understand the paper that we will be discussing, which is, as Antonio told us, microbubble enhanced transcranial focused ultrasound. In order to understand this article written from the lab of Meir Lipsman, we need to understand a little bit more about what focused ultrasound is. And how to do that better than to start with the very basics, which is the blood-brain barrier. Now, as we all know, most drugs are not very effective against intracranial tumors. The blood-brain barrier restricts the entry of many compounds in the brain. On the left, you see a raised cast of the numerous blood vessels that service the human brain. And it shows that the brain is a highly vascularized organ, but it's also highly protected. Now, this protection comes from the blood-brain barrier, and the cornerstone of the blood-brain barrier are these brain microvascular endothelial cells. They differ from other endothelial cells in the body due to the brain microenvironment. They are surrounded by pericytes and astrocytes, which makes it incredibly hard for a compound that wants to get from the bloodstream into the brain, because they are all these different cell types that surround it. But the endothelial cells themselves also look different. They are differently characterized than other endothelial cells. They are strongly connected to other endothelial cells through these tight junctions, which means that any compound that wants to get into the brain has to get through the endothelial cell. But there are also multiple transporters present on these endothelial cells, such as the PGP transporter, which whenever a xenobiotic or drug tries to get in, will be expertly kind of effluxed back into the bloodstream. Now, the blood-brain barrier in the case of a tumor looks a little bit different. It is characterized by abnormal and leaky vessels due to the mechanical pressure that this tumor exerts, as well as different factors it secretes. Loss of these tight junctions disrupt the integrity of the blood-brain barrier and increases the permeability. However, it is good to be aware that this breakdown of the blood-brain barrier in regions of brain tumors is not homogeneous. We have multiple reports, both in vitro and vivo, but also in clinical trials that show that decreasing permeability of the blood-brain tumor barrier in regions that are further away from the tumor core. The regions such as the tumor rim that are closer to the more tumor-free or unaffected brain have a limited permeability and actually resemble the healthy blood-brain barrier quite well, which means that there are leaky, but also none or less leaky regions which coexist in tumor lesions. And it also means that disruption of this blood-brain tumor barrier does not automatically implicate unimpeded drug access. And this makes the blood-brain barrier still very much a relevant problem in neuro-oncology. Now, over the years, people have tried different ways of improving drug delivery through the blood-brain tumor barrier. Cellular routes, as changing different factors on these endothelial cells, but also molecular, for example, by blocking these efflux pumps that I've talked about earlier. But today we'll be talking about a physical and mechanical kind of way of improving drug delivery through the blood-brain tumor barrier, which is FUS. Now, microbubble enhanced focused ultrasound is a way of therapeutic focused ultrasound. It involves intravenously injecting these microbubbles, which then circulate within the cerebral vasculature. You have the focus part of focused ultrasound because you have this MRI-guided targeting, where you will low-intensity focus your ultrasound on. And at this part, at the ultrasound focus, the microbubbles that you've injected will start to oscillate, and they generate this mechanical force on the vascular endothelium. These forces reversibly disrupt the tight junctions and increase the transcellular transport, as is illustrated here, which produces this localized blood-brain barrier opening for several hours. The idea is that because you have MRI-guided targeting, the effect is confined to the sonicated region, while the remainder of the blood-brain barrier in other parts of the brain, the healthy parts of the brain preferably, remains intact. And this will lead to localized delivery of systemic therapeutics. Now, the use of ultrasound for brain tumors has been previously evaluated in various completed clinical trials that use this transcranial focused ultrasound. The study that we will be discussing is the first to report this comparative survival benefit versus standard of care treatment, but it's also using this special ultrasound-enriched biomarker-based disease surveillance called sonoliquid biopsy. The idea of this sonoliquid biopsy is that FUS-induced blood-brain barrier opening enables kind of a two-way trafficking between the brain and the bloodstream. So with your FUS-mediated blood-brain barrier opening, agents in the bloodstream can enter the brain for the treatment of your brain tumor, while actually the brain tumor-derived biomarkers can also be released back into the bloodstream for diagnostic access. And this FUS-induced release of the biomarkers for blood-based liquid biopsy is also called sonoliquid biopsy. The interesting thing about this is that it's spatially targeted. So because you're relocalizing, you have this MRI-guided targeting, you can specifically release, in principle, the biomarkers from a specific region of your tumor. And this makes it different than conventional liquid biopsy. Now, keeping all this information in the back of your mind, I think it's time to dive into the paper with Philipp. I'll stop sharing my screen.
So I think now I'm unmuted. And thanks, Dasha, for the kind introduction. So after having discussed masterfully the rationale behind BBB opening in patients with gliomas, brain tumors in general, I would like to present the clinical trial evaluating this concept in humans. And this is BT008NA, which was an investigator-initiated, industry-sponsored study published in Lancet Oncology in 2025. And that study has been the largest multi-center study investigating MRI-guided microbubble enhanced focus ultrasound in newly diagnosed high-grade glioma. And as Dasha has outlined, even after maximal safe resection, chemoradiotherapy, recurrence in patients with high-grade glioma is basically virtually always occurs. And the infiltrative tumor cells remain protected behind an intact BBB. So systemic chemotherapy may never reach them at an effective concentration in these regions. And the study tested the hypothesis that repeated transient BBB opening with microbubble enhanced focused ultrasound might increase temozolomide delivery. And this could improve local tumor control while also maintaining an acceptable safety profile. So let's first look how the investigators designed the trial. So from a total of 5 institutions, 45 patients with newly diagnosed high-grade glioma, meeting the diagnostic criteria of the WHO 2016 classification of glioblastoma, who received maximal safe resection and are scheduled to undergo standard or have been scheduled to undergo standard radiochemotherapy, were included. All those patients were between 18 years and 80 years old. All of them had newly diagnosed high-grade glioma, and 34 patients fulfilled all inclusion criteria. And the patients entered the study when beginning the adjuvant temozolomide, so when having completed the concomitant radiochemotherapy. It was a prospective trial. It was open label, single arm, phase 1/2 trial with 5 centers across the United States and Canada. And from the treatment schedule, ultrasound treatment was performed during the first 3 days of each temozolomide cycles, up to 6 months of monthly treatment cycles, with the primary endpoint safety and successful BBB opening. And I will dive into more details on how BBB opening has been evaluated. But secondary endpoints were really progression-free and overall survival. Since this was a phase 1/2 trial, efficacy was considered exploratory here. And you can basically see the distribution of the included patients across the 5 different study centers on the right side of the slide, and on the left side you see the characteristics of the patients included. And you also see that virtually half of the patients were unmethylated, the other half have an MGMT promoter methylated status. So from the treatment setup, just to very briefly go through the setup, how it was designed, every treatment started with MRI planning, and the target was manually carefully contoured individually for every patient. And it deliberately targeted the peritumoral infiltration zone. And they did not mainly sonicate the resection cavity. And the infiltration zone, as Dasha has outlined, is important because it contains infiltrating tumor cells. It has a relatively intact BBB, and it's the origin of most recurrences. And once cured, the intravenous microbubbles were administered. Low-intensity ultrasound was activated, scheduled, which activated the circulating microbubbles, and a stable cavitation temporarily opened the BBB, with an MRI immediately confirming that the BBB has been opened, and the opening lasted characteristically only several hours, and afterwards the BBB resealed spontaneously. And this approach allowed localized drug delivery without permanently disrupting BBB integrity. And this is a plot from the supplementary I found intriguing because it tells you a lot about how experience shaped the treatment and how long the treatment actually lasted. So you see here in blue the treatment volume, in red you see the total sonication time in minutes. And on the x-axis, you basically see the study period. And you see that with the study progressing, treatment durations actually decreased, which might reflect improved software, better targeting algorithms, increasing experience by the operators, but also optimized workflow. While the treatment volume increased. So this implies that early focused ultrasound procedures were rather time consuming, but once you become more experienced, the technology behind it becomes considerably more practical with experience, and you feel more comfortable treating larger treatment volumes. So how did the pre and post-operative MRI look like in different patients? There was once a patient where the BBB has repetitively been opened over 6 cycles of temozolomide treatment. And you can see on the preoperative image that the BBB has been sealed. You don't see any contrast uptake in the area to be sonicated or to be treated. And on the post-treatment scan, you see increasing enhancement immediately after sonication. And BBB opening occurred in every treatment and every patient, with the coverage of the intended treatment volume being approximately 90%. And contrast enhancement here demonstrates really BBB permeability, which remains localized, and non-sonicated brain tissue remained unaffected in that trial. So technically, the investigators consistently achieved exactly the biologically effect they intended when extrapolated from the postoperative MRI. So what about the primary endpoint in those patients, which was safety? Overall, 176 adverse events were documented. Around half of them were procedure-related, but really the majority of those treatments effect were grade 1 or 2 and were limited to headache, inside pain, mild nausea, and only 1 grade 3 headache occurred, but no treatment-related deaths, and especially no symptomatic intracranial hemorrhage or no significant cerebral edema. The investigators also made an effort to quantify safety, basically, using the postoperative imaging and quantifying the susceptibility changes and scoring those susceptibility changes on the post-treatment imaging. And they're basically those small susceptibility changes represented tiny petechial changes rather than clinically relevant bleeding. So there was no symptomatic ICB in any of those treatments, which is noteworthy, I think. But the investigators of this trial also made an effort to extrapolate their data in terms of efficacy, not only on safety, which I think has successfully been demonstrated. And since there was no randomized control group, the investigators compared their cohort with a matched cohort coming from one of those study centers and being collected by independent biostatisticians with patient-level data. Matching variables were age, NGMP promoter methylation status, IDH mutation, given that this is pre-WHO 2021, additional prognostic variables, and basically it showed that the median progression-free survival in the cohort of patients undergoing focused microbubble enhanced focused ultrasound was 13.5 months, while the median overall survival was about 31 months, with the hazard ratio approximately being 0.5 compared with controls. I think it's very important here to note that those are external controls, and you cannot eliminate all confounding here, and patients may still differ in ways that cannot fully be adjusted. So those data are for sure encouraging. However, they, from my perspective, should be hypothesis generating. And hypothesis generating should also be any any evidence the investigators delivered in regard to biomarkers. So the novel aspect of the study is that the investigators also collected blood samples before and after each ultrasound session. And the finding was basically that BBB opening increased circulating cell-free DNA with biomarkers trajectories over time correlated with potential disease progression, as you can see in the lower left corner. And this gives rise to a novel concept, which the investigators called a sonal liquid biopsy, with the potential advantage of non-invasive disease monitoring, repeated sampling over time, and potentially even earlier detection of recurrence than MRI. But again, this was exploratory in nature. It's a rather small patient number and requires independent validation. So really to go over each point slowly, the key findings here are that repeated MRI-guided focused ultrasound achieved reliable BBB opening in all treatment sessions. I think that's noteworthy. The procedure demonstrated an excellent safety profile, and adverse events were mainly grade 1 or 2. And the efficacy signals we saw were promising, with median progression-free survival of about 13 months, median overall survival of about 31 months. And but this always has the caveat that this is an external control cohort. And then the investigators also introduced the concept of sonal liquid biopsy. I think this is exciting. It adds an additional application for longitudinal disease monitoring. But the main limitation here really is that this is a non-randomized phase 1/2 trial with externally matched control cohort. So overall, I think BT-008NN provides strong proof of concept that repeat focused ultrasound-mediated BBB opening is technically feasible and safe, while generating encouraging preliminary evidence that enhanced drug delivery may improve outcome in patients with high-grade glioma. And with this, I want to thank you and hand over to Antonio.
Thank you, Philip. Thank you, Dasha. I think that we can open the discussion. We don't have any question yet. Just remind again that ask the question in the question and answer box, not in the chat. And I don't know if Dasha, Philip, have any question to open the discussion.
Yes.
Yeah,
please go ahead, Dasha.
We're very excited
We have
to talk
time.
about this. Yes, we're very excited to talk about this topic. So just maybe as a starting question, I think it's a very cool explorative proof of concept paper to combine FUS with your temozolomide. But of course, we all want to know what other agents you could use, right? Is this something that we could combine with antibody drug conjugates? Should we stick to more standard TKIs or more go towards CAR-T? Would it even be safe with microbubbles? What do the panelists think about the other agents that we could combine with FUS?
I'm happy to answer that. I think it would be very exciting. I know a lot of centers are looking to do that. I mean, our primary focus for this trial was safety, so selecting a group of patients who were not really, they're fit, so they're the beginning of their treatment, so they can participate in this kind of study. It is, as you kind of described, very involved in terms of the procedures and everything. So kind of looking at the ideal patient to participate, we thought that combining with the standard of care was the best way to go. There are also some regulatory considerations when we combine, a very early early study in in such a device with novel drugs. But that's all those different drugs that you've mentioned. People are very excited about combining with in the next coming set of trials.
Cool, thank you. Philippe, you have another question, right?
Yeah, absolutely.
Yeah.
So I think following the discussions we had at last EANO SNOW when discussing basically non-controlled trials, where do the panelists see the role for neuro-oncology trials, which are basically non-controlled but still comment on on overall survival, progression-free survival, considering that any control cohort which has been externally matched comes with the confounding factors that MRI schedules might be different. It's just so hard to compare to external controls, I feel. Do you still see a role for such trials in the neuro-oncology space, or what is the opinion of the panelists here?
I mean,
Yeah,
I would
go
say
on.
I know where Philipp's going, maybe, because we've talked a lot about the value of non-randomized trials, especially in neurosurgery, of course, because we know that there are questions that we cannot answer with RCTs due to ethical problems, of course, where we cannot randomize patients, for example, undergoing different extensive resections. But I think for this case, I think this phase 1 and 2 trial proves at least that we have a basis, that we have a drug delivery platform, I would say, which is now tested to be safe with temozolomide, which we all know and know it works. But I think this is just the start of a milestone to now go ahead and try to design an RCT, even if it's difficult due to the given limitations, testing new techniques, plus maybe then not standard of care ADCs or any other drugs or bigger molecular or bigger targeted therapies. But I would say for this question, I think RCTs are still needed. I see the benefit, of course, of those, statistically sophisticated external controls. I think we've moved far beyond just looking at naive historic controls. And I think all those concepts are getting even better today, but I still think that RCTs are going to be important, especially with these kind of experimental setups.
If I may add something,
Yeah.
Philip, Antonio, yeah, just another dimension is the patient perspective. Like we have one new kind of fancy technology and then standard of care. So if it's a randomized control trial, then I don't know if the patients would be happy to be in the standard of care, not in the advanced kind of technology that might extend the survival, right? So especially in pediatric population that I work with, the parents would not agree to be in the standard of care. So that's another dimension we have to discuss with patients, with regulators on how to design these trials, so that some patients are not felt and they don't feel that they're left behind.
Yeah, I think it's an excellent comment. I think the other perspective there might also be that it's to some extent burdensome, right? It's burdensome to undergo treatment, which takes a couple of hours, to travel to the follow-up scans. It's just burdensome to be on a clinical trial. So I'm not sure whether I would agree that a clinical trial might be the perfect fit for each individual patient. Yeah, but I agree that the patient perspective there is very, very important. So you think, do the panelists, or maybe even you, Antonio, as a basic science researcher, you think that the potential effects of opening the BBB are solely due to the better transfer of chemotherapy inside the brain tissue? Or is there also some other effect, some biological immune activating effect taking place, which you might want to consider there?
It's a good question.
I think.
Oh. Go, Antonio. Well, I can
Sorry,
start.
go ahead, because my daughter is talking. Yeah.
No worries. So yeah, as a question I was thinking about, also we received a similar question from Team Stur in the chat. I think that microbubble must have an effect in the tumor microenvironment in any way. I don't know if there is an increase in neurotoxin clearance, as Tim said, or any anti-tumor effect in the inflammatory part of the microenvironment should have an effect. I would love to have access to that sample to check out and see what is happening in the tumor microenvironment. If it's a reshaping, a remodelation, even in the matrix, the extracellular matrix maybe suffer a remodelating. Dasha or Antonios?
I think I would like to add that from preclinical data, we know that there's a sterile neuroinflammation. but that's not been confirmed yet in patients. So that would be really interesting, but also very difficult to analyze, I think, in a clinical trial.
Yeah.
I would actually love to see any like pharmacodynamic or pharmacokinetic data on temozolomide. I mean, we usually don't do that for temozolomide because we all know the drug a long time ago, but now that we use a whole nother technology, yeah, I mean, trials like window of opportunity trials, where we now tend to want to have a look at what's really going on after we give the trial medication would be interesting in this case as well, to see if there's a direct effect or if there's any, I mean, other effects that you described.
I would agree. My hypothesis that there is something additional to just kind of enhancing temozolomide delivery. We've done some studies with trastuzumab, and that's a much larger drug. You know, the effect we're seeing is probably a doubling or maybe overall doubling of the concentration of trastuzumab. So it's not a great effect, I think, we're having in terms of the pharmacokinetics. We are trying to get lumbar punctures in our patients who we're currently doing kind of a continuation of the study to try to see if we can compare the pre and post CSF to plasma ratio of TMZ in these patients, try to understand how much of an effect we're having there. But I would agree with what people think, that there's probably some other additional modulatory effect. It's just difficult to study in the clinical trial in the time frame you would expect some of these effects to appear. But I think, in designing future studies, that would be a strong consideration.
I think maybe adding to this, I know that from in vivo studies, we know that, for example, those efflux transporters, they're still there, right? You open maybe some parts of the tight junctions, you have some mechanical pressure from your microbubbles, but the efflux transporters also, part of it will pump back into the bloodstream. So it's really a question of how big is your pharmacological effect and how big is your TME. And I don't think we know the extent of our pharmacological effect yet, right? That makes the discussion really hard.
So I love that the panelists, or like basically we all agree that there must be something, let's say, more than just passively pushing temozolomide or whatever agent you're agreeing on over the BBB, coming from all those vaccine trials which have been performed between, let's say, in the last 15 years. There has been the discussion that you might even want to have some sort of residual disease to trigger the immune system being left behind. And this trial has been performed in patients where basically no contrast enhancement has been left behind in the vast majority of those patients. And considering that as surgeons, 40% of the patients where we historically think they are amenable to complete resection, in 40% of those patients, some tumors being left behind. If you would now have to bet your money on a subgroup which is most successful in clinical trial, would it be the one where you have no disease at all, minimal residual disease in terms of contrast enhancement, or even unresected tumors?
Then if you want to say something.
I mean, I'm a neurosurgeon. I would love to be proven otherwise. I still think that bigger extent of resection or less residual tumor volume or disease is important and prognostic. But I mean, I would love to see it the other way. If some study can prove that there's a subset that can really benefit from residual tumor, then I mean, we wouldn't have to be maybe too aggressive in a few cases, or could leave any eloquent residual tumor volume left. Leave this. So I don't know, but this is not data driven, just personal opinion, of course.
I would say of the ones of my kind of anecdotal experience treating who had a significant amount of residual disease, we're not seeing the tumor shrink or go away. So that said, we're not also giving additional immunotherapy or other drugs. So I think I don't really know. But I would agree, probably less tumor better, but obviously that's a complicated question, and I think we don't know the answer. Yeah.
Yeah, another thing we don't know is like the timing compared to radiotherapy or resection as well. Like, is it better to do first ultrasound, radiotherapy, resection, the other way around? So we don't really know in clinical context. We do some preclinical studies on that to see if there's any synergy between the two. We see some synergy. If you do radiotherapy before ultrasound, you see more enhanced opening, and vice versa. If you do opening first, you see more enhanced radiotherapy results, right? So this still is like in progress. Like, what's the best timing, the best frequency? It's very difficult, as you said, to distinguish between different, of course, like disease progression state, as you said. But these are all open questions. We'll do trials to see what's the best outcome.
Well, thank you. I'm gonna read some questions that we received from the audience. Tristan Smith-Lechner, do you think that the benefit of MB-FOS mainly depends on the spatial coverage of the T2 flare abnormal region, or could a specific biological subregion be more relevant target? If so, which advanced imaging method do you consider most promising for defining those targets? Who want to answer?
Yeah, so in our center, we are also starting a clinical trial with FOS-MB. And so we've been discussing T2 flare for a method to delineate the target region, but also looking more into fat bed, for example, to look more into the metabolic tumor volume. But I don't know how Ying thinks about this.
I think that's very cool. We don't. We would also be interested in that. We don't really have the capabilities quite yet. But so far we have been, as you kind of showed that graph where initially we have lower volume that were treated to over time increase volume. Over time we are treating and contouring a greater margin of the tumor and following the the flare signal change. But I think with that trial published, it's a fairly heterogeneous volume targeting that changed over time. So that's something, a limitation of the trial. But I think currently we are mainly looking at a margin and the flare change. Yeah.
Well, thank you. We have an anonymous question here. The trial had an inclusion criteria limiting population to a certain resection level, 2 cubic centimeters. How do the panel see this use in other resection level population? I will modify this question like, why 2 cubic centimeter?
Sorry, why is the 1 cubic centimeter?
2 cubic centimeter, like limited criteria, like inclusion criteria. Need to have the tumor need to have less than 2 cubic centimeter. Why? Neurosurgeons have an idea?
Yeah, I suppose treatment time is a consideration. So when we first started these trials, they were the infusion of microbubble was a limitation. The way that it was infused was through bolus, and it was changed to like a continuous infusion. So sometimes, so the concentration of microbubble given is a limitation to amount of time and in other words, volume that you can treat a patient with. So over time, that's one of the reasons that when we got more efficient with sonications, that's one of the reasons we can expand the volume treated. But there is, if a patient did have too large of a tumor that we can think that we can reasonably cover within one treatment setting, then they, would be not a good candidate for the study. But things have changed, and over time, the treatment envelope has increased. Akke, if you have any.
No, I just had a follow-up question on this subject, because over the course of the trial, a lot has changed technically, just as you mentioned, from bolus injections of DEFINITY to continuous infusion of the microbubbles. The closed feedback loop controller was also changed from the targets to sub-targets, and also larger volumes. Did you also see that during the trial that there was an improved BBB opening, or that patients in the beginning of the trial did worse than patients at the end of the trial? Have you looked into this?
So I believe Pavlos, one of the co-authors, published mostly based on their own, but some of our data as well, the technical aspect of these BB opening procedures. And there's a lot of heterogeneity, exactly as you kind of alluded to. We have noticed over time that we would have more consistent BB opening in patients. There's a lot of heterogeneity, not just in terms of the technical parameters that you get from the system that you're using, but also patient specific to, so tumor pathology, amount of edema around the tumors, those all sort of, in addition, vasculature, obviously we know radiation, radiotherapy affects vasculature of tumors and tissue. So all these factors have a role in the amount of energy you need to deliver per patient for each patient to get. So there's a lot of variability over there. I think with different centers learning over time, I'm sure there is a learning curve, and having better, more homogeneous or reliable BB opening for over time.
Cool, thank you. We have another question from a PhD student at Sorbonne University, Soumi Mukherjee. She's doing a PhD project in a preclinical GBM model using ultrasound, and they found that they can stimulate the cells around the tumor, and also they found changes in the cytokine profile. She's asking if in the patient sample collected, they study something similar, or they found something similar.
Yeah,
Philipp?
I can take that. Yeah. So I think it's a great question. So the investigator did collect patient samples before and after focused ultrasound, but their analysis was primarily focused on circulating cell-free DNA and fragmentomics rather than inflammatory cytokines, and blood was collected immediately before and within 1 hour after MB focused ultrasound, a subset of patients. And they investigated really the changes in cell-free DNA concentration, fragmentation patterns to develop this concept of zonal liquid biopsy. But to my knowledge, they did not report on systematic analysis of cytokine profiles or immune activation. And I fully agree, given the growing preclinical evidence that ultrasound may modulate the immune microenvironment, and we just had this topic, including cytokine release. This would certainly be very interesting for future efforts. Fully agree.
Oh, thank you. I have a question about this. How similar are the blood-brain barrier in the preclinical models to human? Because I'm not an expert on that, unless in the physics of the BBB. But if you have any clue about that, I think it's good to know. Antonius, I see you smiling.
Yeah, I mean, of course, we cannot recapitulate what happens in the human condition, right? So there's 1,000 different models of GBM or DMG in mice, and each replicates maybe one or two specific, traits of the human disease, but the heterogeneity you see in humans is, of course, overwhelming, right? And that's why some drugs work, like TMZ, for example, in U87 cell lines, amazingly. But then when you put them in patients, nothing responds, right? So, it's a big problem. We can do that much to recapitulate what's happening in human condition, but PDX is a solution, like patient-derived cell lines that are implanted in the mouse. But even that, the spatial constriction and restriction, again, it's not the same, right? How the tumor grows, how it responds to different chemotherapy. It's a very valid point, and it's very difficult to replicate what's happening in the human condition, for sure.
Yeah, and to add, the blood-brain barrier in some models are much leakier than in a human. And also PGP is, for example, much higher in mice than in humans. So there's a lot of variability there. Yeah.
Well, at least we can replicate and have an idea that what is going to happen. So we have another question in the chat. FAS was only combined with only 3 dosing of temozolomide, while the remaining 25 dosing were given without FAS. What is the practical frequency and limit of using FAS for drug delivery, or how often can you use FAS? This question is coming from Olaf van Tellingen.
So the way how the temozolomide, I'm not sure whether I get that question right, but because the way how temozolomide is being administered is not that during the entire 28 days, which constitute one cycle, you don't give temozolomide per oral every single day, but you have a certain time at the beginning of the treatment where you basically take the drug, and then you have weeks off, and those days on, weeks off, depending on the schedule. But usually first you basically have the days on, and then you have the weeks off. And during the days on, temozolomide was given because it was assumed that this is where the temozolomide concentration is also peaking in the blood, and this is exactly the time where you want to open the BBB basically, and not during the time when the temozolomide from the circulation might have been washed out, and then opening the blood-brain barrier might have less effect than compared during the time when the temozolomide is peaking in the blood.
Maybe following up on this question, in general, do we have any idea on the durability of the blood-brain barrier opening? Do you have any estimation on how long this lasts? Is it like hours? Is it like half a day? Is it a full day? Is it longer? I know that there's been pretty big amount of preclinical studies on this, but again, as we've just discussed, the models are also not perfect. And a lot of articles, I think, use very leaky models. So I'm curious if we have any clinical parameters to go back on that.
I can comment on that. So, yeah. Sorry, I can go ahead, please.
No, you go ahead. It's fine.
Okay, so yeah, preclinically, as you said, we've seen anything from minutes to 5 days, right? Depending, of course, the parameters, the intensity of the BB opening, also the age of the mouse, for example, or the condition you said, GBM versus wild type, there's a difference in closing timelines. But also clinically, depending on the device you use and the parameter you use, like inside the device, for example, has a low frequency, whereas the implantable catheter device has a higher frequency and different parameters altogether, right? So maybe for the implantable device, you have shorter BB opening timeline, closing timeline, whereas for the inside, it might be a bit longer. So the truth is we can actually control that based on preclinical evidence, how long you want to keep it open for. Of course, the longer you keep it open, the more drug goes in, but also it's more risky in the grand scheme of things. So the answer is we can control this, but it depends heavily on the device and the parameters you're using to treat the patient.
Yeah, and I think to add, it's also dependent on the drug that you want to give. So for small drugs, the blood-brain barrier is open for a longer time, so up to several hours, while for a very large drug, like a monoclonal antibody, it closes very quickly again.
Well, thank you.
Thank you. That's a good question.
We don't have more questions, but I have one question that is more practical. It's like, how many patients can you treat with microbubble per day, for example? If you know that, if the implementation of this technology is real or not, and how many specialized people you need to run this in a hospital?
I can take a first stab at that. I think there are a lot of different systems available. The one that was used in the study is probably, I would say, the most cumbersome one. So this one requires, MRI monitoring, fixation of the head. So the whole setup for that can take, an hour or two, right? So the sonication time itself probably would be less than an hour. So if we were to, that's something that people who use a hemispheric device are trying to work on, is to get rid of the need for MRI every session, and to immobilize the head in a way that doesn't require a frame. But other systems, it would be presumably faster, where you could potentially position the system and you just sonicate straight away. There are other systems where, you put a pin, it's implanted into the skull. So those systems are probably, faster. You can treat multiple, potentially in parallel, you have multiple systems in an infusion center. That's sort of, some of the vision of how this could go in the future.
Oh, thank you. Very interesting.
I would have a follow-up, a comment or rather question on that. Given that there, definitely are some feasibility constraints, or let's say also financial constraints. Those systems are expensive. We know that even not all university hospitals, for example, in Germany, do have FAS. It's still a technique that's not that common. How do we envision, if there's an RCT, if there's more convincing data showing that, for example, FUS and temozolomide is indeed better than standard of care, how do we try to select patients that will get this treatment, or do all patients have to go to specialized centers to get radiochemotherapy, or at least the adjuvant temozolomide therapy then, or how do we go about that? But in my experience in whole Europe, I would say it's not a technique that is available everywhere. So how do we select those patients, or how do we go about that?
I don't know if anyone wants to take that. I have some thoughts too, but I think, if you look at ultrasound neuromodulation, that's kind of a field that's taken off very quickly. There are a lot of different companies interested in building their own prototypes. I think that no one has really questioned how that can be scaled. I feel like one day we can get be opening, if obviously we have to do it right, make sure it's safe, is something more structural is happening, I think, with be opening as opposed to neuromodulation. But I foresee it, we can get to a place where it would be more accessible, less costly for patients. But happy to hear about other people's thoughts.
Yeah, I agree with Ying. So scalability has to do with, of course, costs, like practicality of use, right? So ideally you want to walk in and just in 5 minutes press a button and go home, right? So now it takes some time for the MR guided. In my experience, we've done up to like 3-4 patients a day, but it took like half an hour per patient. In my lab, we're trying to trim that down to 5 minutes, right? So do everything automated and to be easy for the operator and for the patient as well, right? So that's how you can scale to different hospitals and to different countries as well. So I think many of us are working on the scalability of this technology, it's working, right? So we see survival benefit, at least indirect, but I think it's also the technology advancement to allow more hospitals, more users to know this technology and use it actually on a daily basis. But yeah, we're almost there. Like we have phase 3 trials now happening. If we can show this benefit, also the pharma companies might be interested as well. That's another dimension we didn't talk about. But now we talk about device mainly, and TMZ, which is a classic drug. But unless pharma companies are interested heavily on this technology, because we need both pillars to work, the drug and the device, then I think this field will shoot up even more.
I think maybe also considering other patient groups outside the primary brain tumors, but also think of your brain metastases patients. Part of them does actually respond well to systemic therapy, but I think actually a large part doesn't and suffers from these quite debilitating neurological conditions in which they are fully clean of cancer outside the brain, but then they're full of metastases inside. And that, that might be a subgroup again of patients, maybe outside in the general neurological field as well. That could benefit from this fuss, but of course, after we know more about the safety and the efficacy profile.
Cool. So we have 6 minutes. I have a question. Any of you have a question to the panel? Another one? Oh yeah,
I have a
I can go ahead.
question.
Yeah.
Yeah. So I was wondering, so now in this trial we have a survival signal with fus and temozolomide. Should we then, as a community, do an RCT with focused ultrasound with temozolomide? Or should we think, well, maybe temozolomide is not the best drug. We should do another phase 1 trial with a different drug with fus. So which direction should we take?
And also, I will complete the question. What about to include also low-grade glioma?
I would say we stick to what we know best, not mix IDH wild type and mutant gliomas, stick to a selective patient population to just try and see if we can really see the survival benefit in the phase 3 trial. I mean, but I'm also thinking that's what we are all most interested about. This is what we are aiming for if we start with these phase 1 or phase 2 trials. I think there's definitely, there's space to go ahead and do multiple other phase 1, 2 trials to test other drugs, other techniques. But still, the end goal for all these to try to see some real effect in an RCT, right? Even if those external control comparisons are done beautifully, statistically speaking, it's still not an RCT. And we've seen lots and lots of phase 1 and 2 trials, I think every year presented, that have not been translated into clinical practice. So I would love to see an RCT, but this is just for my personal opinion.
And like when contextualizing this trial in the context, given that it's a North American trial in the context of Europe, I feel the way how I would like to see those trials, considering also recent publication of other trials from Europe which have been negative, like the ELIT trial, which was a trial to lit unresectable glioblastoma coming from the Netherlands. I think the most important factor here to be also successful for our patients in Europe is to really build up a working infrastructure between institutions to refer patients which are suitable for such trials to the respective centers in order to generate numbers high enough to fill up the trial slots and to perform those trials on a regular basis, and not each institution cooking its own thing for like 10 years, coming up with another trial, but to be, just to build an infrastructure across Europe, which allows our patients effectively to enter clinical trials which are innovative and promising.
Oh. Someone want to add something else? If not, okay, go Antonio.
Just to mention that there is a phase 3 randomized trial going on, right? The Sonobert trial with a catheter device. So it's ongoing, right? So we should still wait a bit for the results. But there are different phase 3 trials in preparation and not started yet. So just to mention that it is happening, right? It's not like we have to prioritize. Of course, we do a lot of phase 1 trials with different devices, different drugs, phase 2 trials, but there are phase 3 trials happening right now. So we should hear soon about this.
So let's see soon the results. So we need to finish the discussion because we are reaching the 1 hour. Just to finish in, thanks for coming and be here. It was a pleasure to have all of you here participating. It was a really good discussion. And see you in the next EANO Youngster Journal Club. Bye.
Thank you.
Bye.
Thank you. Bye.
Bye. Thanks.